Hello students, I welcome you all to BGY with Mackler. So in continuation with the previous video, now we are going to discuss about the primary amenorrhea conditions. Okay. So in the previous module, we have discussed about those patients presenting with primary amenorrhea, whether the uterus is present in them or not. Now let's discuss about each and every single condition in detail, right? So now the most important is going to be Mullerian agenesis. So actually Mullerian agenesis is a Mullerian malformation, as I have told earlier. Okay, so Mullerian agenesis is actually a Mullerian malformation. That the problem is actually with the Mullerian duct. Okay, since there is absence of Mullerian duct itself, there is going to be no formation of female internal genital organ. And which class of Mullerian malformation is this? This is going to be class 1 of Mullerian malformation, that is Mullerian agenesis, where there is going to be no Mullerian duct formation. Since there is going to be absence of Mullerian duct, therefore the female will never have female internal genital organ. Therefore no female internal genital organ is going to be present in these females. But since they are female, therefore the karyotype is going to remain the same, that is going to be 46XX. Therefore Mullerian agenesis, the karyotype is going to be 46XX. The only problem in Mullerian agenesis is that there is going to be absence of Mullerian duct. Since there is absence of Mullerian duct, there is going to be absent female internal genital organs. Therefore these females will never have fallopian tube, uterus, cervix and the upper vagina. Okay, yes. So let's discuss in detail about this Mullerian agenesis. So the karyotype is going to be 46XX. And we're discussing about the female internal genital organ. Since there is absence of Mullerian duct itself, therefore these patients will never have fallopian tube, will be never there, and then uterus will never be there, and then cervix will never be there, and then upper vagina will never be present in that females. Okay, but the lower part of the vagina will definitely be present. Why? Because the lower part of the vagina comes from the sinovaginal bulb of the urogenital sinus. Am I right? Yes, sinovaginal bulb of the urogenital sinus. The lower part of the vagina is going to come. And then ovaries will also be present in this female. Why ovaries are present? Because ovaries actually develop from the genital ridge. So since these ovaries develop from the genital ridge, therefore apparently these ovaries are going to be normal and lower part of the vagina is going to be present. So since the ovaries are normal, we all know that ovaries are the ones which are going to give us estrogen and progesterone, which are the major female hormones. Am I right? Yes, from the granulosa cells, from the theca cells only we get the estrogen and progesterone, as we have discussed in the menstrual cycle. Yes, so therefore estrogen and progesterone are going to be normal in such females. So ovaries will be normal, estrogen, progesterone will be normal. And then while discussing about the female external genitalia, so whenever speaking about the external genitalia, always keep in mind one thing. Irrespective of whether a male or a female patient, if testosterone is present in adequate amount, then irrespective of whether male or female, they will have a male external genitalia. But if testosterone is going to be absent, then the external genitalia is going to be female. If testosterone is going to be present, there is going to be masculinization of the external genitalia. So male external genitalia will be present. If testosterone is going to be absent, female external genitalia is going to be present. So in a case of Mullerian agenesis, the karyotype is going to be 46XX, a female patient. So since she is a female patient, and then the ovary is going to be normal, because ovaries develop from the genital ridge. Since ovaries are going to be normal, estrogen and progesterone is going to be normal. But in such females, since there is no Mullerian duct, there is going to be no fallopian tube, no uterus, no cervix and no upper part of the vagina. But the lower part of the vagina is going to be present, since the lower part of the vagina is derived from the sinovaginal bulb of the urogenital sinus. Okay, excellent. Now while speaking about the external genitalia, since estrogen and progesterone is present and testosterone is absent in these females, therefore the external genitalia is going to be a female external genitalia as well. Okay, excellent. Okay, now while speaking about the signs of puberty, we'll be taking into consideration 3 things. What are those? One is the breast, and the other is going to be pubic and axillary hair. Remember, in all female patients, definitely androgens will be present, but they will never be present in such a quantity which is present in male. So androgens are present in both males and females, but in females, androgens, that is testosterone, will never be present in such higher concentration which are expected to be present in a male. So androgens are very important for the development of pubic and axillary hair. So androgens are very important for the development of pubic and axillary hair. On the contrary, estrogen is very important for the development of breast. Right? So while taking into consideration, since in patients with Mullerian agenesis, estrogen is present, therefore the breast development is going to be fully developed breast. And pubic and axillary hair, definitely these patients will also have the amount of androgens which are supposed to be present in a female. So they are going to be present in normal female levels. So since they are going to be present in normal female levels, therefore the pubic and axillary hair is also going to be fully developed. Right? So fully developed pubic and axillary hair as well as fully developed breast comes under a staging called Tanner staging. So there is a staging called Tanner staging which is actually used for the development of breast and pubic hair. So this staging tells us about whether it is an early stage of development or whether it is underdeveloped or whether it is fully developed. So Tanner stage 4 and 5 actually stands for fully developed breast and pubic and axillary hair. So it is fully developed. Since it is fully developed, it is going to be Tanner stage 4 and 5. Okay, now I have an important note here that this Mullerian agenesis is also known as Merck syndrome. What do you mean by Merck syndrome? It's very easy. From this term itself, we can write one is going to be Mullerian agenesis. So Mullerian agenesis followed by renal anomalies, followed by cervicothoracic somite dysplasia. So three conditions are going to be present in the Merck's association. What are these Merck's? Mullerian agenesis, renal anomalies, cervicothoracic somite dysplasia. So actually these patients, they will have certain associated problems as well, and since they have associated problem, they are also known as Merck syndrome or MRKH syndrome. What do you mean by MRKH syndrome? MRKH syndrome, it is nothing but M stands for Mayer, R stands for Rokitansky, K stands for Custer, H stands for Hauser. Mayer Rokitansky Custer Hauser syndrome. So basically this MRKH syndrome or the Merck's syndrome, they will have associated renal anomalies and skeletal anomalies. Renal anomalies and skeletal anomalies as well. What are the renal anomalies? The renal anomalies can be any kind of renal agenesis, absence of development of the renal system, renal agenesis, or horseshoe kidney. There is an anomaly in kidney that is termed as horseshoe kidney. Those are the renal anomalies. So in order to find these renal anomalies, what is the investigation of choice? We have to do intravenous pyelogram. Okay, and then we have skeletal anomalies as well. What are those skeletal anomalies? So the skeletal anomalies are going to be hemivertebrae. What do you mean by hemivertebrae? Only half of the vertebrae is going to be present. So hemivertebrae and cervical somites. So Mullerian agenesis in association with renal agenesis and skeletal anomalies, it is termed as Mayer-Rokitansky-Kuster-Hauser syndrome or Merck's association, where Merck stands for Mullerian agenesis and then renal anomalies, and then CS stands for cervicothoracic somite dysplasia. Excellent. So now we have discussed about Mullerian agenesis 46XX. Internal genitalia is going to be absent because of the absence of Mullerian duct. Estrogen and progesterone is going to be normal. In the same way, since the hypothalamus and pituitary is going to be normal, therefore FSH and LH levels are also going to be normal in such patients. So FSH, LH normal, estrogen, progesterone normal, testosterone, that is androgen, is going to be present in normal female levels. Everything is normal. Ovaries is also normal. So the only problem is with the Mullerian duct, where there is absence of uterus. So definitely these patients will have primary amenorrhea. So because of that reason, these patients can never have normal menstruation. So normal menstruation is never going to happen in these patients because of absence of uterus. So definitely they are cases of primary amenorrhea. Apart from that, whether these patients can have their biological children, yes, they can have their biological children. Biological children are the children which are born out of their own gametes, right? They can have their biological children because the ovaries are apparently normal in such patients, but they can't bear the child, right? They can't bear the child in the uterus. Since the uterus is absent, they cannot have their own child in the uterus. They have to adopt some surgery. They have to adopt for surrogacy. Okay, what do you mean by surrogacy? We all know that surrogacy is through having their own biological child through some carriers. So through these carriers, they can have their own biological child. So IVF, in vitro fertilization with surrogacy, they can have their own biological child because the child is going to come from their own gamete, from their own ovary. So through their own ovary, through their own gametes, through IVF and surrogacy in other female carrier, they can have their own biological child. So what is the management of choice in these patients? Since the vagina has only, the lower part of the vagina is only present, the upper part of the vagina is not actually present in that female. Because Mullerian duct only give rise to the upper part of the vagina. So only thing which you have to do in a patient with Mullerian agenesis is you have to create a vaginoplasty has to be done. Why vaginoplasty has to be done? Because these females might have some coital difficulties as well. Because once they get married, they might have some coital difficulties. So the only role of a doctor is to make a vaginoplasty. You have to create a vagina for these females and ask these patients to actually have their own biological child by adopting IVF plus surrogacy. Yes, okay. Now, this vaginoplasty can actually be done through two techniques. One is going to be vaginoplasty, where actually vaginal molds are actually made. So this vaginal molds are actually going to be placed between the bladder and the rectum, and skin thickness graft is going to be taken from the thighs in order to create a vagina. That is vaginoplasty. The other technique is laparoscopic technique. Through laparoscopy, they are going to create a vaginal opening. Laparoscopic VHT technique. So these are the common techniques of vaginoplasty which has to be done in a female. So any female with Mullerian agenesis, uterus, fallopian tube, cervix and the upper part of the vagina is going to be absent. So only two things you have to do. The only thing is you have to create a vaginal opening for such females, and you have to advise them that they can have their own biological children since they have their ovaries normal through adopting IVF plus surrogacy. So this is all about Mullerian agenesis. So let's meet in another important session. So let's discuss the further conditions which we have seen in primary amenorrhea in another interesting module. Until then, please keep studying, students. Bye.